Gary Gottlieb is a professor of psychiatry at the Harvard Medical School who has also played a number of important roles that go far beyond academia. Thus, he has served as CEO of Partners in Health, a global NGO providing a preferential option for the poor in healthcare in severely resource-constrained settings. Before that, he was president of Brigham's Women's Hospital, and then the CEO of its parent company, which also owns Massachusetts General Hospital and is the largest healthcare delivery organization in New England. And as if that weren't enough, Dr. Gottlieb has also served on the board of directors of the Federal Reserve Bank of Boston and as its chair from 2016 to 2018.
So first, good afternoon, and thank you so much, Thomas, for both the kind introduction and for allowing me to participate with this terrific class and with the broader audience that you've created, and to join a panel with you and Jamie to discuss these critical issues. Thomas asked me for this group to set the stage around the clinical and economic issues that face some of the poorest countries in the world as it relates to healthcare delivery, so that we could also speak to trying to get those folks 21st century state-of-the-art treatments as well as we think about pharmaceuticals and a variety of other treatments. And I'll speak to some extent around my experience working as a board member for about a dozen years and the CEO of Partners in Health, and contrasting it with some of the issues in the developed world in regard to delivery. So to start with, per capita healthcare spending in the developing world is frighteningly low. And you can see here that while we often talk about the extraordinary overexpenditure on healthcare resources in the distorted marketplaces in the United States, extraordinary prices we pay for healthcare delivery as well as for pharmaceuticals and devices, the investments made by governments and expenditures overall in the developing world are frighteningly low, driven largely by a lack of gross domestic product, extraordinary and abject poverty, and a variety of demands on the small domestic product that exists as well. And you can see that the effects there in some of the countries of the developing world on key healthcare outcomes are frightening as well, at least 50 times worse than they are in the United States. And we often don't really brag about the healthcare outcomes from a public health perspective in the United States, which is probably about 23rd best among the industrialized world from a public health perspective. This platform creates a high degree of both interest in the rest of the world and a sense of fragmentation without forward-thinking policy. So much of the healthcare in those places also comes as it is targeted by those who might also help to fund it or who participate in that funding that ministries of health have access to. Those include multilateral entities, many of which you're very familiar with, that are either specifically focused or policy focused. But remember, the policies will then drive what happens locally. So the vision of what might happen locally is coming from afar, not necessarily influenced by the desire or the leadership or a strategy as to how that money is to be delivered. And frankly, the complexity of being able to receive these funds in health ministries that have small numbers of people working for them is very, very high, and often money is left on the table. Or for example, there may be indebtedness that's associated with some of that funding as well. And if a strategy goes awry, it will leave the country with extraordinary debt and an inability to pay for other critical resources. At the same time, sometimes these multilateral entities have extraordinary effects. Gavi has been tremendously helpful in both creating markets for vaccines as well as focused on the eradication of specific diseases. For example, most of the obliteration of polio can be attributable to a combination of Gates activities and Gavi and the accessibility of vaccines that was created in that way.
Gary, could I just ask you to speak up a little louder? You're a little bit low energy here, so we need a little bit more volume.
Sure, Jim. I do
Thanks.
worry that it's only your volume that's low, but I'll go for it. Additionally, there are specific bilateral entities, and what that means is that specific government policy divines aid, and that aid somehow has something to do with the foreign affairs and foreign policy of the country. And sometimes that has extraordinary outcomes, sometimes it's selected outcomes. USAID, for example, often works through subcontractors that are American entities. Much of the money that it spends through those American entities, in fact, stay here in the United States. They work on a contractual basis around specific programs. When the funding ends, those programs end. So they aren't left necessarily with sustainable solutions. The CDC, on the other hand, has a broader view, largely in the same way that it does here in the United States, around prevention overall. And then there are some miraculous investments, like the decision that President Bush made to help to fund PEPFAR, in which roughly 18 million people in the developing world have gotten treatment for HIV. However, as PEPFAR sees a variety of parameters, improvements in certain areas, it may make a determination to reduce its funding. And on the other hand, these are chronic treatments, so those countries will still need access to those medicines and the other non-medical components. So arbitrary and capricious decisions that are made far away from a government or far away from a people often have adverse consequences. The governments of other countries are also very much in the investment in aid, none at the size of USAID, which probably accounts for about 80 or 90% of bilateral aid going to the developing world. Clearly, this is kind of a selfish, description overall, because, because certainly China and Russia also have aid. They're in a variety of politically embedded aid programs and partnerships with countries, but they have a set of important medical and social determinants of health outcomes as well. And they are as politically focused as USAID might be, or DFID might be, in its approach in the countries it chooses to support. Then there are a number of private foundations that are deeply involved. They may appear to be almost countries in the multilaterals. So the Gates Foundation has participated with UNITAID and Gavi with making investments that are almost the size of the investments that individual countries have made. But these foundations and many others, and then foundations that are part of specific corporations, where their charitable entities may also have a confluence of interest with the commercial entities, make a variety of investments. So often we see an investment from a pharmaceutical company's foundation in starting access to a specific drug and creating aid or building infrastructure so that theoretically one could create access to 21st century therapies. I'm putting this on the table for you because the interests of each of these foundations may be tremendously positive. It may be politically influenced. It may be related to the politics of the day or a variety of issues. It may be related to the board that's currently involved with that entity, or the views of a specific donor, or the company that's in fact funding them. And while on the other end of this is money and support and a variety of things that could be very good, they're often very fragmented. There isn't a confluence of specific interests. If there's negotiation from the part of a Ministry of Health, there may be tremendous pushback or a diminution of funding or ending funding in a specific way. And very often, these are term loans or term investments. So these are countries that the GDP is not tripling on an ongoing basis. So the notion that we're going to get to that higher proportion of investment to substitute for this in a sustainable way 3 years from now, or 5 years from now, or even 10 years from now is not often the case. And therefore, there's a blessing to this funding, and there's a real challenge to it overall. And in the same way, there are a variety of NGOs, including the one that I ran, that are invested in specific countries and in specific activities, and again, driven by their not-for-profit boards and their sources of funding. So Medical Sciences for Health, MSH, is a Beltway banded-like not-for-profit, which gets 95% of its funding through USAID and other contractors. And it will go into a country, do something specific that is terrific, hire a number of people in that country who are local to work with them as partners. And as soon as that funding is over, they'll leave the country. And that means those people will lose their jobs. The infrastructure will be gone unless that country or someone else has the ability to continue and sustain that investment. Médecins Sans Frontières, a heroic entity, largely heroic in what it does in the midst of emergency. It also does some infrastructure work, but again, it establishes stuff in the midst of emergency, pretty much where it wants to establish them, not necessarily the way the government does, and it negotiates with those governments. So it's not necessarily representing the people, it's representing its priorities, and often will leave when the nightmare is over. And the infrastructure may still sit there, but certainly the human capital doesn't, and the supply chain doesn't in most circumstances. Others of these are extraordinary entities that have a specific focus that is positive and exceptional in terms of the work that they do, but it may waver, may change with who's running the organization. And some of them are religiously focused as well. And therefore, various religious policies may affect the kind of work that's done or who does the work over a period of time. Again, all of these add to the funds overall that are available for healthcare delivery. They may choose the specific geography. It may be in the city, maybe in the country. It may be in a place where the government is working or the government isn't working. They may have policies that include user fees where the government doesn't, and therefore there are barriers to access. These are all very special entities, but think about a healthcare system in a developed place accepting all of these policymakers in lieu of the overall policy. Now that may be possible in the United States where we don't really have health policy, but in general, if you imagine a country that has thoughtful, continuous health policy, the notion that a series of funders that are not in control except by negotiation and other entities are creating the infrastructure is quite challenging. And I'll speak to this from the experience of an entity that is an NGO and that largely is receives as its support unrestricted funds from donors, which theoretically allowed partners of health to stay for long periods of time in places, allow a higher degree of flexibility in making decisions, and whose entire entity is focused on making partnership with the local ministries of health and allowing them to determine what the course and the pathway is through an accompaniment process, whether that's better or worse. It has some outcomes that are associated with it, but it's from that biased perspective. What I wanted to try to give you a sense is that in places that are this frail, in places in which at the baseline, the investments are minuscule, where 3 or 5 or even 15% of a modest GDP is being expended on healthcare, one has an infrastructure that is essentially a medical desert in terms of human capital, in terms of physical capital and infrastructure, and in terms of the ability to deliver on health outcomes that are acceptable in the 21st century. If one piles on that disaster, and a disaster like a pandemic, the outcomes are even more frightening. And we have a recent experience that will likely be extrapolated to what we see when we look retrospectively at all of these countries and what they've accomplished through the Millennium Development Goals and Sustainable Development Goals after this pandemic has riddled their healthcare systems and created essentially tremendous risk for their healthcare workers and the set of demands that they don't have the ability or the infrastructure to respond to, an absence of ICU capacity, an absence of sustainable hospital capacity, and a lack of preventive medicine. So if one takes a look at the pandemic Ebola virus that was just riddled West Africa just earlier in the last decade, one sees some extraordinary infrastructure. So this is looking at 2 different hospitals, one in Liberia and Sierra Leone, and at baseline, as we at Partners in Health entered those places, these were reasonable sized regional hospitals that were in rural areas that had high proportion of populations who are living in abject poverty, less than $2 a day. One of these is in Maryland County, Liberia, that has about 85% of the population living at that level. Another in a large section of Sierra Leone, these are government hospitals that has about 70% of the population living at or below abject poverty level. And you can see things that we would consider basic are absent, and the notion of really responding to acute, terrifying, and nearly universally deadly illness that requires ICU-like intervention, like Ebola virus disease does, and like pandemic COVID-19 does in a large subset of vulnerable populations, would seem to be impossible. This is a comparison in the first, about 2008, and then later reevaluated later in about 5 or 6 years ago, between public hospitals in Sierra Leone and US Civil War field hospitals in 1864. And you can see a substantial number of interventions that one would expect to be available in those places, or that were available in field hospitals during the US Civil War, were not available there. And that's the infrastructure that was inviting this pandemic to its population just a short period of time ago. Just to reinforce this, the Lancet, there was a Lancet Commission on Surgery that was published in about 2016, and calculated that roughly 5 billion people in the world did not have access to a full suite of surgical services at baseline. When I say full suite of surgical services, I mean the ability to do a C-section, to reduce a fracture of a long bone, meaning if somebody has a femoral fracture in their leg and it needs to be reduced surgically, or to do a laparotomy, which is an operation in which one has to open the abdomen. And those are 3 very basic surgeries. The notion of having accessible anesthesia, being able to meet cost requirements, be able to have acute treatment and adequate nursing, as well as a recovery period, is inaccessible to roughly 5 billion people in the world. This is probably 2 degrees worse than that because of the poverty that existed there. And if you take a look here, these were countries that were working on trying to improve a set of preventive outcomes. And during the Ebola, this is in Sierra Leone and in Liberia on your left, Sierra Leone on your right. And you can see that measles vaccines, a basic principle in terms of prevention of child health, basically disappeared during the Ebola epidemic. And similarly, family planning visit, which is one of the keys to both safe development of women, safe development of families, population management in a positive way for those families and giving them that control, as well as being able to follow up with overall general women's health. There's usually a high degree of correlation between family planning and women's health, basically disappeared during that period of time as well. And you can see specific essential services essentially disappeared. Deliveries moved out of health facilities, and I mentioned that because the most important predictor of maternal mortality is delivering a baby in some kind of an attended health facility. Basically, it is the most critical variable in a hospital or in a health center in a way that is attended in this environment. And these are places, and you'll see at a moment, that at the current time, after improvement, have maternal mortality levels of around 1,200 per 100,000. That contrasts with the United States, which needs major improvement and is close to about 18 per 100,000. You can see 61% of those malaria treatments were not being treated, and malaria is hard to treat at baseline for people who have housing insecurity. But obviously, the absence of infrastructure diminishes that remarkably. And obviously, respiratory infectious pneumonias were not being treated as well, which is kind of common cause of death in that environment. So basically, you take a weak infrastructure, a medical desert, as I was describing, in terms of human capital and physical structure. You impose on that something that's scary. And remember, in Ebola, when we lost about 6,000 people in each of these countries, not the massive numbers that we're losing at the present time. This is a pretty frightening number as well. You can see, as I was describing, the tragedy of maternal mortality in those environments, the progress that was being made with attended births, the progress to levels that were still unthinkable, and the reversal that occurred in an instant as a result of the pandemic. Just to show you can do good in these places, just for a second, Partners in Health, which some of you have read about, has a model of accompaniment that was really based on a vision that Paul Farmer, Jim Kim, and Ophelia Dahl had, and created an infrastructure and a paradigm of delivery really based upon a lot of what I think value-based healthcare in the United States is driving for, most of the care being at home or near one's home, then a substantial amount of care very, very proximal to one's home, then lesser care in bricks and mortar, and the least care in highly intense bricks and mortar, highly capitalized enterprises. And basically, Partners in Health brought this model from Haiti to Rwanda by invitation from President Kagame in 2004, 2005. Just to give you a sense, life expectancy in Rwanda 7 years after the earthquake, or 6 years after the earthquake, was just around 40. The healthcare infrastructure had been riddled by the genocide and by poverty for an extended period of time. We went into the 3 most impoverished healthcare districts, and they then extrapolated that work to all of the districts in the country, and this is essentially the power of what they built in and throughout the country, and the outcomes over an extended period of time in key areas were remarkable. Life expectancy in Rwanda, as I said, was just below 40, just around the turn of the last century. This year it will be just under 70. And that is still in a country that has very, very low ratio of physicians and nurses per capita. It's spending 18% of its gross domestic product, like we are, on healthcare, but almost all of it's in public health and in the primary care base that I described before. And it's also a country that demanded control of its aid dollars, where basically the Minister of Health banged her shoe on the table and said, "We're not going to take that for our money. It has to be spent this way. We're not going to take Global Fund money," and got more control of being able to build the infrastructure that way. But the reality is, even if we build these systems, the outcomes are going to be the same if we don't have the ability to bring the discovery, the translation, the brilliance of science to everyone who deserves it, to all 7.5 billion people in the world. We're watching with awe, basically having brought key vaccines to market in a moment in time. We've never done it in less than 5 years, but in a moment in time that is, I've had 2 in my arm right now, and I'm taking care of my granddaughter where I couldn't take care of her before. And how do we bring that to each deserving person who loves their child exactly the way you and I do? So we can build that infrastructure. We can start with community health workers. We can create prevention. We can do primary care. We can then build tertiary care and bring that infrastructure. But unless we can bring that science as well in a way that's affordable, we'll be lost. And so I'm going to try to give you an example. And I like this example because one of the heroes of this area now in terms of MDR-TB is Jamie, who we'll talk to you later, who really stewarded with her work in a pharmaceutical company, bringing one of the first new treatments for MDR-TB to the marketplace in 40 years. And I happen to have lived through that miracle because we were doing clinical trials with it when I was at Partners in Health in 19 of the poorest countries in the world that still has a lot of TB. And just to give you a sense of the effects of tuberculosis, 1.5 million people die a year from tuberculosis now, not then, now. So this is still a ubiquitous and critically important area, and one that's frightening. So Partners in Health, while building the infrastructure I described, discovered that there were a number of patients that were essentially being treated by its overall methodology of care with community health workers, physicians, and others in rural Haiti, and started to discover a subset of those folks were not responding to tuberculosis treatment. And they were doing daily observed treatment, but more than observed treatment, where they were also buying people food, making sure they had housing security, and a variety of other elements as a whole in terms of that infrastructure. And the subset of people weren't responding. And it turned out that those people had TB that was resistant to multiple drugs, which, because, as you've learned about viruses, mycobacteria mutate as well. And essentially, when somebody is exposed to a set of drugs in a complicated toxic regimen of even the first line treatments, where people are taking multiple pills a day that make them depressed and feel sick and nauseated and lose weight, and they have to take those drugs in first line treatment for 8 months, when people are taking them, if they stop because there's a flood, because they run out of money, because there isn't access to medicine, because their mother-in-law died, or whatever reason, if they stop taking it for a period of time, the tuberculosis becomes, in fact, resistant to the entire intervention. And there's a subset that are essentially resistant to almost everything or resistant to a lot of different drugs. And therefore, another high level of drugs are necessary to treat them. And remember, in that overall compendium of drugs, several of them, and the most potent ones, have been injectables over a period of time, where people in these crazy rural settings where they're having difficulty taking care of their baby and the roof is caving in, have to in fact get the medication injected on a daily basis or on a weekly basis, depending upon the medicine overall. So you can take a look as Partners in Health started to try to figure out how to manage this conundrum and was having difficulty accessing drugs. And you can see that there's a high degree of variation in price of these drugs in terms of cost for a year of treatment overall. If you multiply the number of people they were treating, these costs were really extraordinary. They were trying to figure out some policy solution. They felt like they were shouting into the wind as policymakers said, look, it's impossible to give these people treatment. PIH proved that they could give them treatment with community health workers. Who's going to create the money for this? Clearly, who would shift markets in order to essentially either bring the pharmaceutical companies, distributors, or pay attention to some of the critical issues you've talked about in this course to be able to bring to the table. And so the folks at PIH and their partners, a guy named Howard Hyatt, who is an extraordinary pioneer in this area, put together a meeting at Harvard and brought together thought leaders in this area and policymakers, many of whom said, you know, you can't get these people better, despite the science that Jim Kim and Paul Farmer showed, in which they were able to show this improvement. And this meeting created a high degree of interest in this area to try to figure out how to affect policy. While they created a submission overall to add second-line anti-TB drugs to the WHO model of essential drugs to essentially create the beginning of ways in which the markets could be shifted and large purchasing and governments could become involved and aid would be available. They also started to study and realized that virtually all of these drugs were off patent. That none of these, this was not the control of pharmaceutical companies per se. These drugs were all off patent that weren't being protected in terms of the patent, yet the prices that were on the global price lists were all over the place, many of them extremely high. And they basically put together an Open Society Institute report from George Soros's group on the global impact of MDR-TB, which kind of put together the pressure around seeing this global and continuous epidemic, the number of lives that were adversely affected, and the challenge in terms of treatment overall. That created the formation of a policy concept that I want you to keep in mind as you think about the proposals today. They put together the Green Light Committees, and they used a model that they had used in successfully disseminating meningitis vaccine, because the first meningitis vaccines were discovered in the late 1960s, early 1970s. And there was a terrific set of collaboratives to try to disseminate them in the Arch of Africa in the early 1980s, and then again later in 2000. And the model seemed to work in shifted markets and create a set of principles that the WHO would purchase and procure the majority of the supply. That would then change the marketplace. It would assure the quality of the product. It would grant access based upon compliance with the guidelines of how the drugs would get to people. So remember, here's the drug. Before I told you about the infrastructure. So you need to have the infrastructure on the delivery model and prove that to us, and then we can give you the medicine so you're not going to make more people treatment resistant. And to basically have guardrails as well as toll booths in that regard, and got a group of entities to be able to support that. Doctors Without Borders and Médecins Sans Frontières agreed to procure all the drugs and to provide approved programs at cost. Again, this is the great use of an NGO in this regard. Eli Lilly, WHO, and the Doctors Without Borders began negotiations on supply of two of the critical drugs, and Lilly supported the idea of the Green Light Commission, which basically there's a big dog here that says this works for us. We're willing to make compromise. We can change the marketplace. And then generic manufacturers followed. And you can see the prices declined precipitously and extraordinarily and made these treatments available to people, and made them available in a way that one could have a sustainable solution to a horrific set of events, but used essentially science, then policy, and then a change in that policy, then a set of compromises that brought industry and government and multilaterals and NGOs together, and then created a solution overall. And this problem has not gone away. The fact that there was a headline around doing this for MDR-TV, I mean, frankly, some of the same work supported the reason why the Global Fund made the major investments in being able to fund HIV, and ultimately PEPFAR, basically sustained that in a broader way. But if you take a look at the hierarchy of needs for people with diabetes, or the treatment of diabetes, it really starts at the basic possible level. One needs to do testing. One needs to be able to have all of the laboratory stuff that's available, and to be able to do it point of service, to have rapid turnaround time. It's not easy if you're living in a deeply rural setting with no access to clean or running water, to be able to be sticking your finger every day. And there's no way to get those meters calibrated. There's no way to get supplies for them. One has to start with the supply chain. Then one has to move to essentially the essential medicines, both various forms of insulin as well as oral hypoglycemics, and move the entire hierarchy up to being able to make those kinds of shifts. And insulin can be manufactured for as little as a couple of bucks. It's priced anywhere from that $4 a vial in some low resource settings to more than $300 here in the United States. And you can see that what that cost is as a multiple of the kinds of wages that exist in the developing world. And at the end of the day, the average life expectancy of someone diagnosed with type 1 diabetes in most areas of sub-Saharan Africa is about 1 year. I mean, just 1 or 2 episodes of ketoacidosis in a place with no ICUs is certain death. And most of folks have their first episode of ketoacidosis as children or late or adolescents, and so it's a horrific outcome overall. So, and additionally, I tried to show some price changes here so you could see the effects of a lack of control of medication prices on delivery in the way that I described. And this is a set or a series of off-patent medicines that have been off-patent for a long, long time. These are 20th century medicines. Okay, these are mid-20th century medicines that aren't even the state of the art of care in most of the areas that they're used. And prices are just, the generic manufacturers are just, basically manipulating the prices or increasing them, or the distributors are increasing them on an ongoing basis. So the notion of those market failures obviously are costing lives and creating suffering. So this is kind of the background. It's kind of I hope at least some landscape for you to see that can, I think, speak to some of the issues that Jamie's been wrestling with and helping to lead us to make real change around.
That's fantastic.
Just my question is for Professor Gottlieb, and it's not really vaccine specific, but more to do with the provision of aid by organizations and NGOs. And I've interned for a period of time at a specialized hospital in Yemen before the war and after. And what was difficult to miss was that as the war progressed, the problem shifted from the lack of infrastructure that was mentioned. So there was a lot of aid available, but not much infrastructure to effectively provide aid to those in to that part of the population living in rural areas. But now it seems to be the problem that NGOs and other organizations are quite hesitant to provide any aid or as much aid as is needed or even close to that, because of the policies within the country, because of the corruption, because countries like Yemen are asking for, well, what could be construed as a bribe, and because of the blockade, the difficulty in importing medication, bringing it into the country. And I was wondering if you could maybe share your opinion, starting points perhaps for solutions for this problem.
First, thank you for the work you did in Yemen. is about the most complicated place in the world, and suffering about the most horrifying set of iatrogenic tragedy as a result of warring powers destroying the infrastructure of the country overall, both its economy as well as each element of security, including health security, and it's sitting in the middle of probably the worst cholera epidemic on the face of the earth, with massive death and suffering that's been ongoing, and basically a power battle among those who want to have spheres of influence, and no rational policy for the country. So it'd be hard for me to give you an answer and a solution to Yemen per se, but the issues of the association of unstable government, numerous forces within countries, particularly associated with various political factions, the potential for violence, and what we describe as corruption in governmental or institutional corruption in the context of abject poverty, or fits and starts in that poverty and then a maldistribution of wealth are ubiquitous. And they are the symptoms of instability and suffering in many, many countries. I think that the approach that we've tried to take is to partner with the government, but to partner in a way in which the aid that at least could be transferred would be transferred in regard to specific services and activities rather than cash payments. Clearly, there's always going to be loss. There's loss in the supply chain. There's loss in the pharmaceutical supply chain. There's loss in food supply chains because of black markets, because frankly, everyone who's around any of those goods and services is trying to keep their own family from dying. And the local economies are at best informal. And the informal economies usually are probably 2/3 of the true GDP of these countries, and therefore people who have power have the ability to disrupt those supply chains and those resources. But in general, the more from the perspective that at least PIH had from its mission and other effective NGOs that I've seen has been try to partner with the people. The only strength one has that represents the people is at least the government at any given time, but to essentially abet the government's processes with services that are consistent with mission, and that cannot flow to really any other activity because there aren't cash goods and services, and to be able to build the infrastructure that can be sustainable for whichever government is in power. And of course, what happens in revolutionary environments or in the midst of war is that infrastructure is destroyed and disrupted in the way that I described to you when I showed you those places that are medical deserts. But it's key partnership, not cash goods and services, specific activities focused usually in places where there's the highest poverty.